plateau iris can occur in any of those situations, and that gets the other thing that we need to keep in mind. So what is the role of an early lens extraction versus YAG-PI? So Thomas has already showed you this, and this basically says that when you have PSCS and you're following them up, PSC and following them up, 28.5% progress to PSCG. 1 out of 9 eyes progressed in spite of a patent YAG-PI, and 7 out of 19 eyes progressed without a YAG-PI. And that was the basis for the decision, that's saying that all eyes with PSC should undergo an LPI, which is the guideline that we have been following. So if you have primary angle closure, there are two possibilities. You can either have sine K with or without raised IOP, or you can have no sine K but with raised IOP. All eyes undergo LPI. Post LPI, there are again two situations. One, you may have a persistent narrow angle post LPI about 25% of the time, or you may have open angles post LPI. So basically, from our point of view, in these two eyes situations, the problem is solved. We really don't need to do anything else. For these two, maybe there's a physiological basis for lens removal. The same situation appears in primary angle closure glaucoma. Occasionally, of course, you do get apposition persistent in plateau iris even after cataract extraction, and that's usually because of the presence of iridociliary cysts. Most of the time, cataract extraction does open up the angle. So this study was done to look at the effectiveness of early lens extraction for the treatment of PSCG. And it's an Eagle study. So the questions that we have are basically, does it help with angle control? Does it help with IOP? And does it help with disease progression in terms of disc or visual field? And these are the inclusion criteria. So PSCG, you had to be more than 50 years, you had to have a field effect, or you had to have any of these changes on the optic disc. You had to have an IOP of more than 21 millimeters of mercury at least one visit. For primary angle closure, in addition to the narrow angles, you need to have at least one IOP of more than 30 millimeters of mercury. So it wasn't all primary angle closures, it was a highly selected group of primary angle closures. So you had to have 180 degrees or greater of appositional or cynical closure for inclusion. And the results, basically, they looked at two things. They looked at quality of life, and they looked at intraocular pressure. Since this study was also funded through the UK, quality of life becomes an important thing for them, because when you're looking at public health, that's an important metric. And the difference in quality of life, and this is on a scale of 0 to 1, the difference was those who had lens extraction were 0.052 points better than those who did not. So 5% difference in the quality of life. In terms of intraocular pressure, a 1.2 millimeter better intraocular pressure control at the end of the thing. So in terms of the baseline characteristics, if you continue the clear lens extraction versus the LPI group, axial lengths were marginally lower, but significantly higher refractive errors in terms of hyperopia in the clear lens extraction group. So did the clear lens extraction removal of hyperopia improve quality of life is a question that has not been answered. In terms of Second question is, what is the relevance of a 5% difference in quality of life? Is it actually better? If you look at the primary outcome, second primary outcome of intraocular pressure, you had IOP was 1.2 millimeters less in this group as opposed to the YAG-PI group. And this was actually less than the IOP that the study was designed to measure. They actually were expecting to see at least a 1.75 millimeter difference in IOP, and they saw much less than that. They were also supposed to see a 15% lower glaucoma surgery rate, which was not seen. So the study did not meet the minimum IOP criteria that they thought should be significant in order for the clear lens extraction to be primarily better. What about the angle? And this is the question that we have, because we said that our problem is not with in the eyes that where the angles open, the problem is with the eyes that where angles don't open. So this is at baseline. They had slightly less information about gonioscopy in the clear lens extraction group. There was missing data in this lot. At the final visit, 65% of patients had missing data in the clear lens extraction group, and 50% of patients had missing data in the YAG peripheral iridotomy group. In terms of the cynical angle closure, how much cynical closure was there was 60% data missing in both groups. So it doesn't really tell us anything about the angle, which was something that we're really, really interested in when we're looking at lens extraction. So our questions were, In the Angl, there is no additional information. In the IOP, there's minimal difference, and disc and visual field changes were actually similar between both the groups. So in primary angle closure, lens extraction probably opens up the angle if there is residual closure. There's no justification for early lens extraction if IOP and angle are well controlled, and you should always do a YAG PA to see if the angle opens up. And if glaucoma surgery is planned, of course, you could consider adding surgery. So if are we justified in intervening surgically in eyes with PSCG with IOP controlled on medication that have a clear lens? At this point in time, there is no justification for us to do it. We should continue to do what we are doing, except in eyes with a very exaggerated lens vault. And even there, I would consider doing a YAG PA before I do anything else. So without significant cynical closure and open angles, the risk of progressive angle closure is very small. And the only advantage that you might have is to potentially reduce the number of medications. I'll also consider that this is a population where accommodation is important. Once you cross the age of 60, 65, when your accommodation is gone, it's a separate issue, but the mean age of the study was less than that. And cataract extraction is not without its complications in difficult angle closure glaucomas. So thank you, and I hope we have time for some discussion.